Dr. Dewi Irawati from the Department of Medical Physiology, FMUI. Welcome to the distance learning video presentation provided by the Department of Medical Physiology, FMUI. This is the second of two parts video that will discuss about immediate cardiovascular responses to aerobic exercise. On the previous video, we have discussed about physical activity versus exercise, aerobic versus anaerobic exercise, and oxygen uptake. In this presentation, we will talk about immediate cardiovascular response to exercise involving changes in cardiac output, heart rate, stroke volume, blood pressure, and blood flow distribution. Cardiac output is a product of heart rate and stroke volume. During exercise, heart rate and stroke volume increases, hence cardiac output will also increase. Increase in heart rate and stroke volume is caused by an increase in the sympathetic tone. At a certain point, an increase in heart rate will no longer be sustained by the increased stroke volume because of the reduced filling time of the ventricles. This point is known as the maximal heart rate, and at this point, maximal oxygen consumption is reached. Further increase in heart rate above the maximal heart rate will reduce cardiac output. The increase in cardiac output is needed to fulfill the oxygen demand of the working muscles. We will see redistribution of the blood flow throughout the whole body. The percentage of cardiac output going to the skeletal muscles and heart will increase. The percentage of cardiac output going to the skin increases as a way to eliminate the extra heat generated by the exercising muscles. The percentage of cardiac output going to most other organs is reduced. The magnitude of blood flow to the brain remains fairly unchanged. There is a linear correlation between maximal oxygen consumption and cardiac output. That is why VO2 max is considered to be one of the best indicators of cardiovascular fitness and has been shown to be a key determinant of endurance exercise performance. It has been demonstrated that the skeletal muscle's ability to utilize oxygen far exceeds the capacity of the cardiovascular system to deliver oxygen. Thus, cardiac output becomes the limiting step and explains 70 to 85% of the variance in VO2 max in different individuals. The heart rate. After the initial anticipatory response, heart rate increases in direct proportion to exercise intensity until a maximum heart rate is reached. At the beginning of exercise, heart rate increases rapidly due to the inhibition of parasympathetic tone. During light exercise, tachycardia is solely due to the reduction in parasympathetic tone. With increased workload, heart rate increases due to further vagal withdrawal and sympathetic activation. If exercise intensity remains constant, heart rate will level off. This is known as a steady-state heart rate. At this point, demands of active tissue is adequately met by the cardiovascular system. Increase in heart rate is determined by the fitness level of the person. Even though the maximal heart rate that can be reached by two persons with the same age is equal, but for the same workload, a fit person will have a lower heart rate compared to an unfit person due to more efficient work of cardiovascular system. This will be explained in another lecture. Notice the different slope of heart rate increase with exercise intensity and the speed of heart rate recovery after exercise cessation in fit and unfit person. However, when a person continues to exercise for a prolonged time at a constant workload and steady-state heart rate has been achieved, a further increase in heart rate will occur. This is known as cardiac drift. The further increase in heart rate is caused by the increase in body temperature, which causes a shift of fluid from the blood vessels to the skin, reducing venous return. In order to maintain the same cardiac output, the heart rate will increase. At this stage, a person will feel like they are expending more energy than they actually are. This may create a mental block and inhibit one's performance. To prevent or minimize this effect, fluid replacement, maintenance of electrolyte balance, and acclimatization to the environment is important. Next is the stroke volume. Stroke volume is the amount of blood pumped by each ventricles during ventricular contraction. Two mechanisms are involved that affect the strength of cardiac contraction. First is the Frank-Starling mechanism. The law states that the stroke volume of the heart increases in response to an increase in the volume of blood in the ventricles before contraction. Secondly is the neurohormonal influence. Increased sympathetic activity to the heart will increase the strength of contraction. Stroke volume clearly differentiates people with high and low VO2 max. Individuals with low stroke volume will also have a low maximal oxygen consumption. Thus, differences in VO2 max closely resemble the difference in maximal stroke volume. Here is a summary of factors affecting cardiac output. Heart rate, which is influenced by the autonomic innervation, hormones, fitness level, and age. Stroke volume, which is influenced by heart size, fitness level, gender, contractility, duration of contraction, and diastolic volume, and total peripheral resistance. The next cardiovascular parameter is the arterial blood pressure, which consists of systolic blood pressure and diastolic blood pressure. Systolic blood pressure is the pressure in the arteries following contraction of ventricles as blood is pumped out of the heart. It is increased when contractility of the heart or the stroke volume is increased. Diastolic blood pressure is the pressure in the arteries when the heart relaxes and ventricles fill with blood. Diastolic blood pressure is determined by the resistance in the peripheral blood vessels. During aerobic exercise, systolic blood pressure increases in accordance to workload. However, diastolic blood pressure remains steady or slightly reduced. The increase in systolic blood pressure is caused by an increment in cardiac output, while peripheral resistance is maintained fairly stable by local factors. After a bout of sustained light to moderate intensity exercise, systolic blood pressure temporarily decreases below pre-exercise levels for up to 12 hours in normal and hypertensive subjects. Pooling of blood in the visceral organs and lower limbs during recovery reduces central blood volume. Hypotensive recovery response further supports exercise as an important non-pharmacologic hypertension therapy. Blood flow distribution. As mentioned before, there is a redistribution of cardiac output towards different organs. Most of cardiac output is delivered to the exercising muscles. What causes the change in blood flow to various organs? Two mechanisms contribute to the shift in blood flow. The first mechanism is local control, brought about through myogenic hypothesis and metabolic hypothesis. According to myogenic hypothesis, when vascular smooth muscle cells and arterioles are stretched, mechanically gated channels in the muscle membrane open, causing depolarization of the membrane. Calcium that then enters the cell triggers the muscle contraction, thereby acting to resist the initial passive stretch. According to metabolic hypothesis, a decrease in tissue oxygen supply, local increase in temperature, carbon dioxide, acidity, and other substances stimulates local vasodilation. The second mechanism is neural and hormonal control. Most systemic arterioles are innervated by sympathetic neurons. Tonic discharge of norepinephrine from sympathetic neurons helps maintain myogenic tone of arterioles. Among the hormones with significant vasoactive properties are atrial natriuretic peptide and angiotensin II. During exercise, blood flow to the working muscles is mostly influenced by local control, while changes in other systems of the body is regulated by neural and hormonal control. Next is blood volume. With the onset of exercise, there is an immediate drop in blood volume. An increase in blood pressure during exercise causes an increase of hydrostatic pressure, which forces water out from the vascular compartment to the interstitial compartments. Secondly, buildup of metabolic waste products in active muscles causes an increase in intramuscular oncotic pressure, which attracts fluid to the muscles. Thirdly, loss of fluid during sweating means more sodium loss from the intravascular space and increases osmolarity in interstitial space. This attracts fluid from intravascular space to the interstitial space. Hence, we will see a reduction in blood volume during exercise. In summary, immediate cardiovascular changes that occur during aerobic exercise includes an increase in heart rate, stroke volume, cardiac output, mean arterial pressure, and systolic blood pressure. Diastolic blood pressure stays the same while total peripheral resistance is decreased. These are some of the references that we used in preparing this presentation. We have reached the end of our discussion. We will discuss about adaptive cardiovascular responses to aerobic exercise in another video presentation. Thank you for your attention.